Hello, and welcome back to Err Is Human, Why We Keep Screwing Things Up and What to Do About It. For those of you who are just coming through the videos, welcome to part 3. For those of you who are doing the homework, I hope that since reading Thelma LaBelle's book, as you interact with your physical environment, you're more conscious of, or at least in complete awe of, how much those physical interactions, how much that sensation is actually influencing you in ways that you never realized. So, part 3, I am the master of my mind. So we're going to talk about bias, and I want to be clear that what we're talking about are the biases that are the mental shortcuts that allow us to think efficiently. We're not really talking about explicit prejudicial bias. Yes, that is a form of bias, and when we refer to someone as biased, that's the response that we see is to the idea of that prejudicial explicit bias. That is, people get angry, they get offended. That's not what we're talking about. So Merriam-Webster defines bias, and I like the first definition because I think it's important in thinking about the ways in which bias influence our decisions as systematic error introduced into sampling or testing by selecting or encouraging one outcome or answer over others. Now, there's also a more personal, less scientific definition that Merriam-Webster gives, and that's an inclination of temperament or outlook, and in particular, a personal and sometimes unreasoned judgment. Now, you can see how if someone were calling you temperamental with unreasoned judgments, you might get offended. But I want you to think about the denotations of all those words. That is what they literally mean. And by understanding them, we'll get a clear picture of what bias truly is. So let's start with inclination of temperament or outlook. So it is a perspective. Facts are real. Facts matter. Facts are true. Facts that are proven are true. How we interpret facts in the context of the rest of the world, in the context of our lives, in the context of our experiences, that's personal. Everyone perceives the world from their own viewpoint. No one has the same viewpoint as anyone else. And we'll go through lists of biases. And while we may be able to say that 2 people or 10 people or 1,000 people are all exhibiting the same bias, how they exhibited it, what it means in their world is different for every one of them. So it's a personal judgment. And I think most importantly, I would say it's not sometimes unreasoned. I would say that unconscious bias is always unreasoned by definition. Later on in this series, we'll talk about System 1 and System 2 thinking. Biases are used in System 1 to be able to be efficient, to move fast. They're probably evolutionary drivers for all of our unconscious biases. It's fun to think about them and think about when might it have been useful in our evolutionary past to our survival for this particular bias to be in operation. And today, we can look at our own lives and realize that biases can be incredibly helpful in terms of navigating the tremendous amounts of information that come into us. Nonetheless, by their definition, because they are shortcuts, we do not use our reasoning mind to think through those judgments. They are unreasoned. And that's why bias in this sense is so problematic for us. It's unconscious. It doesn't come up to our level of awareness, so we don't know we're doing it. Because we don't know we're doing it, it's very hard to control. And because we can't control it, because we can't think our way through it, it is unreasoned. So bias in the unconscious, non-pejorative, non-judgmental form is unconscious. You don't know you're doing it. You really can't control it, and it is not something that we use our reasoning mind to understand. So I want to talk about some biases and give some examples, and my basis for this will again be from my profession, being in medicine. So Dr. Semmelweis, professor of medicine, delivers lots of babies. The time when he's doing this, lots of women are dying of postpartum fever. That is, they get infections during the delivery process and they die. Now, nobody knows they're getting infections. It's just postpartum fever and then they die. So he's a professor. He delivers lots of babies. Just like his colleagues, his patients die, good number of them. So he goes on vacation and the nurses deliver his babies. And the nurses, not being nearly as important as doctors, well, they take care of one patient at a time. They focus on that patient. That's the patient they're caring for. And their patients don't die of postpartum fevers, or at least not at nearly the same rate as the physicians. So he comes back from his little break, and he looks around and he thinks, well, now this isn't good. If every time I touch a patient, she's got a high risk of dying, and every time the nurses take care of the patients, they don't, I must be doing something wrong. That's some pretty good insight there. So he thinks about it and he realizes that being born is a really messy process. And there must be something he's doing because his hands are getting contaminated, that he takes that contamination from one patient to the next and introduces it into the next patient, and then they get an infection. And so he does something radical. He washes his hands between patients, and they stop dying at ridiculous rates. So Dr. Semmelweis says, I'm onto something here. And he goes to his medical society and he presents this, and he gets drummed out of medicine. He loses his license because he challenged an orthodoxy of the organization. Something that's really quite trivial. It's not like he was saying that physicians need to cut off their small fingers between each patient to prevent infection. It was wash your hands. And yet, because it was so deeply ingrained in the physician mind that hand washing did not matter, they could not tolerate that challenge. So anytime you see someone being drummed out for challenging an organizational belief, a strongly held belief of an organization or society, that's the Semmelweis reflex. Naive cynicism is the belief that you and you alone can see the world as it really is, and anyone who disagrees with you, therefore, must be a biased fool. Now, certainly, the people that you're dealing with, disagreeing with, or agreeing with are all biased, but so are you. Availability bias is the idea that something that is foremost in your memory, something recently put in, is more immediately available to you in your decision making, and therefore is likely to influence your decision making more than something that was put into your memory a long time ago. So if the last 10 patients that you see with chest pain all had pleurisy, when patient number 11 comes in with chest pain, you are much more likely to say, I bet it's pleurisy, than you are to list any other diagnosis. And so if you're not careful and you don't consider what the other diagnoses can be, just looking at that patient, even if the picture doesn't fit, the diagnosis of pleurisy will be first and foremost in your mind. In confirmation bias, we tend to take those facts that confirm our theories and give them a lot of weight. Aha, that is an important result. Whereas those results, those pieces of information that would argue against our theory, I've seen that before. It's not that important. Sometimes it just doesn't happen. And we do that all the time in medicine as well. When we make a premature closure to our workup, premature closure to a diagnosis or an encounter, when we say early on, I know what this is, and then we start our workup, well, what happens is as the facts start to come back, if we had been open-minded, they would paint a very clear picture of a given diagnosis. But because we thought it was a different diagnosis, we'll discount those facts that disagree with us and put heavy weight on those facts that agree with our initial theory. The law of the instrument, we all know this. If all you have is a hammer, everything looks like a nail. And that can apply to management techniques, that can apply to technologies, that can apply to procedures. People tend to use their strengths, even if they're not the right strengths, and it's true with organizations as well, even if they're not the right strengths for the situation. Epiphania is seeing order in random data, and the visual form of this is why we see Elvis on so many pieces of toast. But in medicine, we also come up with diagnoses out of random data because we're seeing a pattern that's not really there. And then the law of small numbers is one that catches us all the time in evidence-based medicine. So we think of statistical significance, a p-value of less than 0.05, as having some important meaning about truth, that if something is statistically significant, therefore it must be true. Well, first off, it's true 19 out of 20 times. That's kind of the point of a p-value of less than 0.05. But even more to the point, when your study has a very small sample size, that significance doesn't mean the same as the significance in a very large sample size. And so when we compare studies, and we've got a large study, 4,000, 5,000 patients, that gives us one answer, and then we've got 10 small studies of 60 to 80 patients each. Even though those small studies all disagree with the large study, and they all agree with each other, and they're all statistically significant, those small numbers have much less meaning. The p-values have much less meaning than for the large number. But we forget that in medicine, and we often don't have good big studies, so we treat small studies as if they had the same significance. Now, another place we see this is in patient satisfaction surveys. We get return rates of less than 10% on these things. We may get, in a 1-month period, an emergency department that is evaluated on 6 responses, despite the fact that they see 4,000 patients a month. And to think that there's statistical value in those answers, it's statistical foolishness. And yet, much weight is put on those small numbers. All right. So those are things you can think about in your own life. Now I want to talk about these 3 other biases. Now, there are hundreds of biases, but these 3, the ones I'm pointing out, are ones that we encounter frequently in medicine, and the next 3 we encounter very frequently. So, you're an emergency department physician, you're seeing a 58-year-old male with crushing substernal chest pain, right in the center of his chest. It feels like an elephant sitting there. His EKG shows tombstone ST elevation and leads V2 through V5, a classic ST elevation myocardial infarct, or STEMI, the ones we rush to the cath lab or we give clot-busting medications to. So we're going to transfer this patient to the cath lab, which is right across town. 15 minutes into the transfer, the patient goes into ventricular fibrillation cardiac arrest. So whenever patients die on us, those cases go to our quality improvement process. And one of the things that's noted is that there's a 58-second delay in getting out and opening the defib pads. So there was a delay in defibrillating this patient in ventricular fibrillation. So your peers at the Morbidity and Mortality Conference believe that you should have seen that coming. I mean, this was a STEMI. How could you not have seen cardiac arrest coming? Why would you not have the pads ready to go? So this is hindsight or outcome bias, what we call Monday morning quarterbacking. It's this belief after an event happens that obviously it was going to occur, and that even before it occurred, it was obvious that it was going to occur. And there are a number of conditions that promote this kind of bias. So the impression of inevitability. Someone with a STEMI, we know that's bad disease. People die of it. How could they not have this event happen, this VFib? The cause and the effect are clearly related. This patient would not have had VFib if they weren't having a STEMI. This is foreseeable. We know that patients with STEMI go into VFib. We know they go into cardiac arrest. You can see this. And it's not surprising that that happened. So all of those conditions promote the idea that the outcome was obvious even before it occurred. So how do we fight this? Well, first, think about why the alternative didn't happen. In this case, why didn't he not have a cardiac arrest? In his particular case, was there something exceptional that made it happen? Require justification of the claim that it was inevitable. Every patient that you see with a STEMI goes into cardiac arrest? Do they all die? No. No, the odds of a different outcome, the odds that he would not go into cardiac arrest, are much, much higher than the odds he would go into cardiac arrest. And so, as we're analyzing events, we need to look at them through those glasses. And if we are the subjects of an analysis and we believe that the decision, the judgment about what we've done is being colored by hindsight or outcome bias, these are the ways to counter that. And this, unfortunately, is what happens in the legal system all the time. Lawsuits don't happen unless someone perceives that there was a bad outcome. And therefore, we're starting at the end already assuming there was a bad outcome and therefore judging the events before we even know what happened. Okay, so you are a primary care physician. You're seeing a 78-year-old woman. She had an acute COPD heart failure exacerbation. She was in the hospital for a couple days, and she's discharged, and she's coming into the office for follow-up. So you've got a 20-minute follow-up slot because we know we've got to get people through quickly. And you need to do a medication reconciliation and a history and a physical exam and review and discuss the labs that were drawn yesterday because they changed a bunch of her meds while she was in the hospital, and coordinate with home health because she needs follow-up, and set up some follow-up labs and a repeat chest x-ray to make sure that everything's cleared. Oh, and she mentions that her 84-year-old husband, who's not your patient, has also seemed to be confused since he was home alone while she was hospitalized. And so in doing all that, you forget to check yesterday's labs. And you missed that because they decreased her Lasix but kept her on some potassium supplementation, that her potassium is 6.2. Well, what happened? We are hardwired, for the most part, to be optimistic. We overestimate the probability of good, pleasing outcomes. We like things to go well. And because we like things to go well, as we make plans, we underestimate the amount of time it takes to get things done. Anyone who has ever had a contractor do work for them recognizes the planning fallacy. Well, now, when we talk about how long a physician should have to see a patient in follow-up, well, we're optimistic. They can get through all these things. We've got support systems in place, and we underestimate the amount of time it takes to get things done. So this leads to slips or lapses. As you'll recall from our part one of this series, those are two types of errors that could occur when you've underestimated the amount of time it's going to take to do what you need to do. So how do we prevent this? Well, first off, it turns out pessimists are really good at estimating how long it takes things to happen. Not perfect, but better than optimists. Also, learn from your planning errors. If this happens, don't flog yourself and say, how could I have missed that potassium? And if you're an administrator, don't flog the doc and say, how could you be such an idiot? It's so important to check those labs. Instead, say, what conditions made this possible to happen? And was there something we did? Was there a planning fallacy that led to this? And then one of the things that we do with our paramedic students all the time is we have them time themselves doing common tasks. So how long does it really take to start an IV? 2 minutes? 3 minutes? Well, from end to end, getting everything out, opening up your IV kit, prepping the site, prepping your line, actually getting the line, securing it, cleaning up, it can take 8 to 10 minutes. But people don't think about it. They think of just the very brief procedure of putting the catheter in itself, and then they say, and then it takes a little time to do the other stuff too. So if you actually time yourself, you can get a good sense of how long it takes to get actual tasks done. All right, so this is one we've all seen. CMS wants to improve treatment for hypertension. So there's a bunch of directives that are put into place that facilitate this. And they're going to require every 3-month office visits with a nurse and every 6-month office visits with a provider until 1 year of sustained blood pressure control is achieved and maintained. This is a good thing. Hypertension, uncontrolled hypertension, very, very bad. We want to have people's blood pressures controlled. It's a contributor to all sorts of different types of disease processes that are debilitating, have high morbidity as well as high mortality. So there's a rural office, and they don't have enough provider and nurse appointments to be able to do this. But they read the barbershop hypertension studies. They understand the importance of social networks, like real human being social networks, not ones that exist in the ether. And so the office partners with the local bowling alley. It's a pretty rural community. That's what they've got. That's where people go. And so they actually have a marked improvement with medication compliance and blood pressures. So they meet those guidelines. But because they don't have the capability of getting people into the office, 70% of the time, this results in them failing to meet the office visit requirement of a nurse every 3 months and a provider every 6 months. And so CMS says, you're not meeting the guidelines. So the office doesn't get paid for those patients, despite the fact that they're getting better blood pressure control than other offices, and the providers are listed on the CMS website as low quality for value-based purchasing hypertension management. That is, they get censored for failing to meet the markers, despite the fact that their outcomes are better. So this is called surrogation. And this is what happens when we lose sight of the strategic goal and that the measure is intended to represent and actually act as if that measures the goal. In other words, we think that the marker is more important than the outcome. So first, always remember that a surrogate measure of a thing is not the thing itself. If you're looking at the thing, hypertension control, look at that. Markers are useful because we get to hypertension control by doing a series of things. It doesn't just happen. The outcome isn't a standalone thing. But there's more than one way to get to the outcome. And just because we've chosen a pathway and are measuring these surrogate markers doesn't mean that there aren't other, and in certain contexts, better ways of doing this. Always recall the strategic goal in the context of those measures. So remember that the measures are just measures. The strategic goal is what you want to have. And particularly thinking about serial time measures that combine to make a strategic goal. This is important in things like door to open artery time for ST elevation MI or door to drug time for stroke. That if you have a system of doing things that the overall time is shorter, but some of the markers end up being longer because of the way you do them, that doesn't necessarily mean that you're doing a bad job. Even so, at the end of that, even if you say, you know what, those markers are idiotic, I can get a better outcome doing it my way, loop back after the fact and see if, in fact, there would be a good reason why you should meet those markers. Because maybe if you shorten your door to EKG time or your door to lab time, even though your current process, it doesn't matter that it's a little bit longer. If it were shorter, that might shorten things even more in ways that you can't really see. So that's constant incremental improvement, and it also spreads across processes. So even if it might not make a difference what your door to lab times are for your acute stroke patients, if you can use that marker to drive improving door to lab time, it might help you in your sepsis patients. Okay, so bias. It's there. It is something that we need to be aware of, and as we talk about System 1 and System 2 thinking, it becomes even more important. So what's your homework? I want you to read Shankar Vedantam's The Hidden Brain, How Our Unconscious Minds Elect Presidents, Control Markets, Wage Wars, and Save Our Lives. And if you don't listen to the Hidden Brain podcast, I'd suggest doing it. It's just humbling in a lot of ways to think about how little we actually know about ourselves. And then once you've done that, I want you to answer this question. Have I ever been fully aware of all the reasons why I made a specific decision? Pick any decision. Think about your biases. Say, did I know absolutely why I made that decision? Or could there have been unconscious biases operating? All right, well, again, thank you for your time. This was a bit of a longer session. Most of the rest will be shorter. Enjoy the homework, and I look forward to seeing you in part 4.